Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/WUM860. This activity is supported by an educational grant from Lilly.
Good morning or good afternoon. Thank you very much for attending this lunchtime symposium entitled Safeguarding Patients with Hormone-Positive, HER2-Negative, High-Risk Early Breast Cancer, a Practical Roadmap for CDK4/6 Inhibition in the Adjuvant Setting. I'm Steve Johnson from the Royal Marsden Hospital in London, medical oncologist, and I'm joined by my colleagues Patrick Nevin from the University of Leuven in Belgium and Joyce O'Shaughnessy from Breast Cancer Research Program at Baylor University in Texas. We'll introduce each of us to our relevant sections as we go along. So our goals for today are to enhance your ability to identify patients with hormone-positive, HER2-negative breast cancer who are at high risk of recurrence and could benefit from adjuvant CDK4/6 inhibitor therapy. We want to enhance your skills for formalizing individual treatment plans based on the latest evidence and the key factors to consider, and then expand your repertoire of strategies, in particular for managing adverse events, because that's something that a lot of clinicians are a little bit nervous about with using particularly abemaciclib, which is what we'll be discussing today. So let's start with a case. Tina is a 57-year-old postmenopausal patient. She's a real estate agent. She travels frequently for work. She presents to your clinic with a symptomatic mass in the right breast, and further assessment and then subsequent surgery reveals the following: 3-centimeter mass clinically with involved lymph nodes, biopsy grade 3 invasive lobular cancer, ER 90%, PR 25%, HER2 negative. Biopsy of the lymph nodes is positive, PET staging is negative, and BRCA testing is also negative. Because of the size and the patient's wish, she proceeds to a mastectomy and lymph node dissection, and we have a 2.3 centimeter, grade 3 lobular cancer with 1 out of 3 involved lymph nodes. So our agenda today is split into 3 segments of roughly 15 minutes each, 10 minutes for presentation, 5 minutes for a debate amongst ourselves around some of the key topics. And we'll look first at how we conduct risk assessment to identify patients. Then we'll look at the latest data for adjuvant CDK inhibitors, and then we'll have a session looking at mitigating adverse events and maximizing treatment benefit. So at this point, I'll hand over to my colleague Joyce O'Shaughnessy from Baylor University in Dallas, Texas. Joyce.
Thanks, Stephen. Hello, everybody. Glad to be here with you today. And so my job is to help us think through who's high enough risk in our practice that we would think that they really should have a CDK4/6 inhibitor. So these are both relatively recent data sets. On the left from the IBCSG, trials 1 to 5, kind of a meta-analysis, the HR positive population. We can see these are annual hazard ratios for recurrence that we're looking at here, hazard rates. And we can see in the orange, the 4 more lymph node positive patients, they're really very high risk. And that risk continues out even beyond 10 years. So both at risk short-term and long-term, the 4 more nodes. And then the yellow is the 1 to 3 node positive population, and they have also kind of a broad swath of risk here that also continues out beyond 10 years. And then the node negative population, again, not an insignificant risk here early on. It gets lower as time goes on. But, you know, I think many of us who have been taking care of breast cancer patients for a long time realize that we still have patients not only at risk early on, but we have a very large population at risk for later recurrences. And I was involved in helping put this data together on the right here from a large real-world evidence database in the US, very long. It's a 26-year surveillance of patients, stage 2 breast cancer, stage 3 breast cancer. And we see that going out here 15 years, going out even out to 20 years, we see that well more than 50% of patients will eventually have a recurrence, even with relatively modern day therapy. So we still have major issue even with our chemotherapy and our endocrine therapy in early breast cancer. I think one of the best data sets we have as a community to look at very well done prognostic information in the adjuvant setting is the SOFT and the TEXT trials. These biomarkers were all analyzed centrally on the SOFT and the TEXT, which, as you know, were the LHRH agonist question in premenopausal HR-positive patients, and published in JCO by Meredith Reagan and Olivia Pagnani. And just very, very nicely, we can see how we're looking at distant recurrence. The younger the woman in the premenopausal population, the greater her risk, really quite substantial. We can see once again, top right here, that those with 4 or more lymph nodes positive really indeed have a very high risk, both early on as well as continuing, much less in the 1 to 3 lymph node, but I dare say we follow these patients long enough, those curves are likely to meet up, and much, much less in the node-negative population. ER is a very important prognostic factor as well. We certainly know it's very strongly predictive for benefit from endocrine therapy, and if it's less than 50%, patients have a much worse outcome. And tumor size here, T1 in orange, T2, T3 in purple. We can see, again, the risk that these patients experience. PR is very important as well. The bottom 2 curves are less than 20% or 20 to 49% of cells positive versus greater than 50%. Again, worse outcome. Key 67 as well, very much of a stair step in terms of prognosis, particularly dictating the risk of early recurrence, the Key 67. And then tumor grade is indeed very powerful. We can see how well this splays out here with the grade 3 patients at much higher risk early on. Of course, the grade 2 patients could have a later risk of recurrence. So these are very helpful, practical ways for us to think about patients with standard clinical pathologic features. Of course, we do rely quite a bit on the 21-gene recurrence score. These are the tamoxifen alone data in the NSABP B14. 5 years of tamoxifen. We're very well aware at how poorly patients with high-risk disease did. Very, very rapid recurrences, really no benefit from tamoxifen. The intermediate-risk patients as well, a not insubstantial risk of recurrence in this node-negative group. And I think the work by Mitch Dowsett has really shown us that the recurrence score is largely based on the degree to which the cancer is endocrine therapy sensitive. There's really a very strong linear relationship between the strength of the ER module, the transcriptional activity of the estrogen receptor, and the recurrence score, not so the proliferative status. That's really not what drives the 21-gene recurrence score. It's really how well is the patient going to do with endocrine therapy that drives the 21-gene recurrence score. And this was put together by Peter Schmid, this nice table summarizing the data here on the left from the RxPonder and Taylor X trial. And in the pink, C is chemotherapy plus endocrine therapy, and green just endocrine therapy alone. We have the premenopausal population, the postmenopausal population. And I put this here because I think many of us feel that if a patient's high enough risk to receive adjuvant chemotherapy, then that's a patient that we want to give some very serious consideration as well to a CDK4/6 inhibitor. And you know, it's very straightforward in the postmenopausal population, 4 more lymph nodes positive or a 21-gene recurrence score greater than 25, whether they're node negative here or 1 to 3 node positive. As you well know from the Taylor X and the RxPonder trial, it's not just 4 more lymph nodes or greater than 25 on the recurrence score. There are patients with more intermediate risk who are premenopausal who also benefit from adjuvant chemotherapy. The same was seen with the 70-gene signature, the MammaPrint in the MINDACT trial. Patients who were clinically high risk but genomically low risk, who had 0 to 3 nodes positive. Clearly, the postmenopausal patients did not benefit from chemotherapy, but the premenopausal patients, again, did benefit from adjuvant chemotherapy. We know there was an issue with all 3 of these trials because of the time and history that they were launched. Less than 20% of the premenopausal patients in all 3 of these trials received an LHRH agonist. And as you know, as a community, we're left with that question about whether it was chemotherapy that was basically taking the place of an LHRH agonist, and that's why chemotherapy was of benefit in these patients. And The offset trial is ongoing in this premenopausal population, all in the pink here, not 4 more nodes, but in the pink, where patients are randomized to chemotherapy plus optimal endocrine therapy, an LHRH agonist plus AI, versus an LHRH agonist plus an AI alone. But it'll be 10 years before we have the results of that trial. So what can we do in the meantime for those patients? Well, we know that one way to define a very high-risk population that won't benefit particularly well from endocrine therapy is to treat the patients with preoperative endocrine therapy. This really pioneered in the UK many years ago, and looking at patients who do not suppress, the group 3 patients do not suppress their Ki67 with endocrine therapy. Group 1 suppresses very well, and group 2 is intermediate. And that is actually quite a practical way. And this was like 2 weeks of preoperative endocrine therapy. You can see down here, this is the PEPI score of 0 with very, very strong suppression of Ki67. And, pioneered here in Germany, the ADAPT trial, very nice, I think, being increasingly utilized around the world for patients with HR-positive, HER2-negative breast cancer. That upfront biopsy is sent for a 21-gene recurrence score and Ki67. If the Ki67's greater than 10%, receiving 3 to 4 weeks of preoperative endocrine therapy. And then if the 21-gene recurrence score is between 12 and 25, and the patients have a suppression of Ki67 to 10% or less with a brief course of preoperative endocrine therapy, they are treated with endocrine therapy alone. If they don't suppress, you can see up here, then they do receive chemotherapy, or if they're N2 or N3 or have a high recurrence score, they're treated with chemotherapy. So this is a way to try to identify a lower risk group of patients who will benefit from endocrine therapy alone. And as you know, this prospective level 1 evidence trial in the IDFS, all patients here, if patients suppress to 10% or less their Ki67 without chemotherapy, now in the blue, we see that they do indeed very well. And those who do not suppress, have a Ki67 still greater than 10%, have a worse outcome. And that is true even in the top right here. These are the patients under the age of 40 in the top right. Even those who suppress, they do very, very well. And just a minority of them actually had chemotherapy. But if they don't suppress, then they do indeed very, very poorly. So this is a way, I think, to help us for individual patients until we wait for the results of the offset trial. And it also is a way to really help us understand who we might be able to avoid chemotherapy in. So these are some of the criteria we think about to identify that high-risk group of patients. It really, I think, boils down to endocrine therapy resistance. Patients who are going to do very well with endocrine therapy have a much lower risk of recurrence, but endocrine therapy resistance is really the key feature of the high-risk population, especially at risk for recurrence within 5 years. We know standard clinical pathologic features that by themselves, as well as in combination with gene expression signatures, really can help us identify high-risk patients. Lower ER levels, higher proliferation does increase risk of recurrence because endocrine therapy sensitivity is less. These 3 subsets, which we don't routinely assay for in practice, luminal B, HER2-enriched, and basal-like HR-positive breast cancers, are clearly less endocrine therapy sensitive and are high-risk patients. And then importantly, failure of preoperative endocrine therapy to suppress Ki67 also predicts for poor outcome with adjuvant therapy. And so these patients are really candidates for escalating therapy to try to optimize their outcome.
Thank you very much, Joyce. So that's a lovely summary of the clinical pathologically as well as the molecular genomic and dynamic Ki67 changes that we can now got at our disposal to assess risk. So let's return to our case. Remember, she's a 57-year-old postmenopausal patient with a grade 3 lobular cancer with 1 involved lymph nodes. So I'm going to ask my colleagues here, Patrick, do you think we now have enough information just on the straight-hand side, on the left-hand side from the pathology, to really have a proper understanding of her risk of recurrence? And in particular, the lobular versus ductal, do you think that makes a difference here?
Yes, if we have such a patient that we discuss on our weekly tumor board meeting and the multidisciplinary assessment, we would say that this patient in Belgium is eligible for a gene expression profiling. So we would do a mama print or an Oncotype DX to give us more information, because something is wrong with this tumor. It's ER strongly positive, PR is suboptimal, it's grade 3, so it's clearly high risk, but it's lobular. So what does that mean? That these gene expression profilings have not been extensively tested in lobular breast cancer, and we know from Nadia Harbeck's work from Plan B that they are more likely lower risk than the ductal breast cancer. So we cannot rely very much on the gene expression profiling.
And while we think a lot of lobulars are usually grade 2, the grade 3 is perhaps more likely to be pleomorphic lobulars. Do you think that changes the aggressiveness of the cancer in terms of its endocrine resistance or chemosensitivity at all, or do we not have enough
We know
data?
that these lobulars that are not grade 2 and grade 3, pleomorphic lobular breast cancer, it's not mentioned here, but it might be a very bad prognostic factor. So I think, yes, it does matter, yes.
So we do order an Oncotype, whether it be an Oncotype, a Prosigna, or a MammaPrint, it all gives us relative information. And Joyce, the score is 21. She's postmenopausal, and we get a Ki67, but not a dynamic Ki67, so it's a baseline. And we've got a lot of fun and games about cutoffs and so on, but it's landing in at 15%. What do you think that really tells us about her individual risk of recurrence and the implications for treatment, in particular, say, chemotherapy? We'll come on to endocrine treatment in a minute. But if you had that additional information and you were seeing a patient, what would you say to her and what would you start to discuss, particularly in relation to chemo?
I think she is, I agree with the participants that I think she's a high-risk individual. I think she's got a high risk of recurrence. If it's pleomorphic, it may be a higher risk earlier on, although the Ki67 would say maybe her risk would be a little bit later. But with the 21, the recurrence score of 21, I would not offer her chemotherapy, because the reality, as we all know, is you can be high risk and still not benefit from chemotherapy. So this is a patient I would not be enthusiastic about chemotherapy for, but she still is high risk.
Okay, fine. So let's move to the second part now, which is to look at the evidence for CDK4/6 inhibitors based on the latest data, and I'll present this to you now. So this is all based on the Monarch-E trial, which you're familiar with, and was updated at ESMO in September by Nadia Harbeck, and now published in JCO last month. So to remind you, this was a trial of high-risk hormone-positive HER2 negative patients based on nodal status. So they were all node positive, either 4 or more nodes, or if 1 to 3 node, at least one of the following: grade 3 or a large tumor size. There was a second smaller cohort of only 9% of patients where they had intermediate clinical features. So perhaps a grade 2 or 1 tumor, less than 5 centimeters, and it was 1 to 3 nodes, but the only factor was a high Ki67. So after completion of standard surgery, radiation treatment, and chemo, and 95% of the patients in the trial got chemo, they were randomized in an open label to either endocrine therapy alone, potentially up to 10 years as they were high risk, or endocrine therapy plus abemaciclib for 2 years. Primary endpoint was invasive disease-free survival with secondary endpoints that you can see. Now, the latest analysis was a planned interim overall survival analysis, but a chance to look at the mature invasive disease-free survival data with median follow-up now of 4.5 years, or 54 months. So all patients are now off their abemaciclib, and more than 80% have been followed for 2 years beyond completion of the abemaciclib. So we now have very mature data to look at the degree of benefit. And these were the IDFS curves presented at ESMO and now in JCO in press. And you can see here that at 5 years, there is an absolute gain of 7.6%, representing a 32% relative reduction in risk of developing an IDF event. 2 things I always point out on this is just look at the blue curve. matching to what Joyce was telling us earlier. So these patients with 4 or more nodes, or if 1 to 3 nodes and a grade 3 or a large tumor, they have a steady rate of relapse. They've all pretty much all had chemotherapy. They've all had good AI therapy on their own, but 1 in 4 will relapse by 5 years. And you can reduce those 25% who are relapsing by nearly 8%, so a third will be prevented by the addition of a CDK inhibitor. Equally, the separation of the curves is early, and then following completion of treatment, the curves continue to separate. So treatment benefit continues beyond completion of therapy, what we call a carryover effect, which may be affecting the natural history of the disease in a good proportion of patients. Benefit is seen in all the predefined subgroups. We haven't presented yet the actual difference between lobular and ductal, and that is one of our planned analyses at the moment, but there is no individual group that derives more or less benefit on the pre-specified subgroups. This is the distant relapse-free survival, so that's metastases or death for any cause, so it takes out local recurrences, and very similar shaped curves and absolute and relative benefits. The survival data at the moment in the trial are immature because we haven't reached the number of events in the statistical plan for the final overall survival analysis. Patients live with breast cancer, even if it's relapsed, for a prolonged period of time. So in a large adjuvant study, you have to follow it for many years before you get survival data. But the numbers are moving in the direction where there are fewer deaths now on the abemaciclib arm, 208 versus 234. And if you look at these histograms at the different analyses done in 2021, 2022 in the middle, and 2023, you can see here, shaded in gray, the deaths not related to breast cancer, the deaths in blue, which are due to breast cancer, and then in the sort of turquoisey color, you can see the patients who are sadly relapsed with metastatic disease, alive, still receiving treatment. And what you can see is the evolution here of far fewer metastatic patients, nearly half as many in the latest analysis, and in due course that may well translate into quite a marked difference in deaths related to breast cancer. So it's important to continue to follow these data. Now, oncotype is something we've discussed there, and there was a lot of interest as to whether or not benefit from adjuvant abemaciclib is greater in those patients with a high recurrence score or with those with a low recurrence score. And these data were presented by my colleague Nick Turner at San Antonio, where a significant amount of translational research has been done in this trial, and we did an inferred 21-gene oncotype on all of the patients. This was a biomarker group that was selected for IDFS events using a case cohort design. And you can see in the pie chart, about 70% had high recurrence score. Why? Because they're mainly node-positive grade 3 tumors, so they're higher risk cancers. But about 30% had low recurrence scores, less than 25. And what you can see in the forest plot here is that the absolute benefit of abemaciclib was similar whether you had a low recurrence score or a high recurrence score, using the cutoff of 25 that is used to determine whether you give chemotherapy or not in this patient population. Now, there's a lot of other biomarker data that is coming out. There was some other data at San Antonio on ctDNA, and this is the ability to detect cell-free DNA from the tumor at baseline and understand whether that is a risk factor, a prognostic factor for early recurrence or not. And what you can see in the bar charts there is that if you detected ctDNA at baseline, it was relatively few, but 7 of the 10 patients relapsed then if they had positive ctDNA. If you then developed ctDNA on treatment from negative to positive, all of those patients relapsed. So it is looking like it could be a strong prognostic and predictive factor for recurrence, and more data will be presented in 2 weeks' time by Shireen Loy in a late-breaking oral abstract at ASCO. So the recommendations in terms of approval, both in the US and the European Union, are for what we call cohort 1 in the trial, that if patients have high-risk features of 4 or more lymph nodes, or if 1 to 3 lymph nodes, a large tumor size, or a grade 3 tumor, all of which we know predicts for a roughly a 20 to 25% risk of recurrence, at 5 years, then adjuvant abemaciclib is indicated for those patients. You'll recall in the US that they originally approved it only if you had additional biological features of a high Ki67. But when the latest data from the trial came out, they opened it up to all patients in cohort 1, regardless of Ki67. Now, there is another trial, just for completeness of what the data with CDK inhibitors are at the moment, which is the NATALY trial. And these data were presented virtually a year ago at ASCO, and then updated at San Antonio, and now published in full peer review form in the New England Journal just a month or so ago. And this was the NATALY trial, similar size, but a different population. It included some node-negative patients, some anatomical stage 2A, and if they were 2A and node-negative with grade 2, they had to have high features on either Ki67 or a high oncotype recurrence score. So it's a wider population, but it includes now node-negative patients. Ribociclib was at a lower dose of 400 milligrams, and duration of treatment was for 3 years. So subtle differences compared to the Monarch E, but otherwise relatively similar design. But all patients were given a nonsteroidal aromatase inhibitor with ovarian suppression if they were premenopausal. And the trial is positive at its first interim analysis. You can see here that the patients in the control arm have a better prognosis than the Monarch E control arm because they include a wider group of lower stage patients. And the absolute difference at 3 years is 3.1%. The relative reduction is 25%. The data presented at San Antonio with an additional 5 months of follow-up showed that the ratios and the absolute difference didn't change. But what we then saw was an analysis by nodal status. And these were the San Antonio data that show the curves separating in both node positive, who have a worse prognosis, and in node negative. But I point out that in the node negative, it's a relatively small percentage overall of the trial in terms of the numbers of patients, and the number of events is very small, 20 versus 31. And as soon as you go beyond 36 months, the number of patients at risk is down to only a handful. So it's really important that we continue to follow the data, particularly in the node-negative patients. Their overall survival, likewise, is immature at this point in terms of the differences between the two arms. So returning to our case and having a discussion here about the adjuvant CDK inhibitor data, remember that we have a patient who is one node positive, and she has a 2.5 centimeter tumor, lobular, but it is grade 3. So on those criteria, would she be high enough risk? So Patrick, what do you think you would offer this patient based on that, and would you discuss CDK inhibitor therapy with her?
Yes, if it's stated like you said, grade 3, and we have this drug, abemaciclib, available in Belgium, we would give it.
And if the patient had a grade 2 tumor, then she doesn't necessarily fall into cohort 1 because she's one node positive, she is 2.5 centimeters, but she's grade 2. And a lot of lobular cancers are grade 2. So say you repeated the analysis of grade and it was more a grade 2, you're strictly speaking not within the criteria. Joyce, what do you think the grading is all important here? It comes back to what we were talking about, pleomorphic versus non-pleomorphic. We feel that she's not getting chemotherapy, but we don't feel strong enough that she is low enough risk to just need endocrine therapy. But say it was reported as grade 2, what sort of discussions would you be having in your tumor board?
I think she'd be a great person for tumor board so we can see the actual pathology, because grade 2 is not often uniform. And Ki67 is not uniform. So it would be interesting to see if she's got heterogeneity of grade. She may well have, if this is pleomorphic-ish, she may have an area of grade 3. So I think I would go looking for this. I think this cancer is a fairly high-risk cancer, and I would look to see if there's an area of grade 3. Sometimes in the US, in her case, if she really is purely a grade 2, and the Ki67 is 15%, I probably would, once ribociclib is available, in my mind, she would be more of a ribociclib candidate. If the Ki67, however, she was in the cohort 2 of the Monarch E, a lot of times we are utilizing that, that information to still pursue abemaciclib.
Yeah, no, if she had been reported as grade 2, she wouldn't have even made it into cohort 2 because she's a Ki-67 of 15%. But one pathologist's 15% could be another pathologist's 23%.
And we could discuss because it might be that this lady was on hormone replacement treatment, that she stopped it and she had a lower Ki-67 than the one was in her first biopsy.
You go back to the first one too and,
Yes.
and look at that as well.
Yeah, it comes back to understanding individual biological level of risk. And this is where I think if we could do some more preoperative endocrine-based therapy treatment in the lower anatomical risk group, we could identify those that were still resistant to that treatment, where we definitely know the CDK. But if, say, she had a Ki-67 that was 20%, she came off her HRT, you gave her letrozole, and the Ki-67 was down at 3%, then we know from POETIC and we know from ADAPT that those patients have an excellent prognosis, and whether or not they would benefit from CDK inhibitor becomes a little bit more nuanced, I think, doesn't it? Yeah, I mean, and Joyce, in terms of biomarker data, do you think that this is going to change how we practice? So ctDNA is very much at its exploratory phase in terms of its prognostic value, but it looks quite promising in these higher risk patients that if you have ctDNA or you develop it, it's a strong indicator of risk of recurrence. Do you foresee a day when that will come into clinical practice?
I do think so. I think the data sets are still small, but they're very, very consistent that if you have the development of or persistence of ctDNA positivity in the adjuvant setting, that you have a very, very poor prognosis. The vast majority of patients will recur within 2 to 3 years. The reason it's not standard, of course, we don't have anything to do about it right now. We need data, but I will predict that once we have data showing interventions, showing clearance of that ctDNA that persists in patients, that it's something we will look at even before we have necessarily a lot of systemic outcome data, although it won't be hard to get. You won't need large numbers because patients have such a poor prognosis. If they either develop it or persist, it wouldn't take that many patients to show improvement in outcome.
No, and as I said, we'll see more data from this trial at ASCO in a couple of weeks because we've done an awful lot of translational work to really drill down as to where the benefits are seen. Finally, before I move on, Patrick, say the Oncotype recurrence score had moved the other side of 25, pick a number, 28. Our exponder suddenly says, well, you should give chemo. Patient's not very keen. Can CDK inhibitors replace chemo?
Well, today we still don't know, but these studies are ongoing. The people from Germany here, they have a randomized trial where this is going to be assessed by ribociclib versus chemotherapy.
That cycle,
Yes,
yeah.
cycle, yeah.
Yeah, so this is a common question that clinicians and patients ask, and there is a randomized trial to assess that in these sort of intermediate risk scenarios. So these are the sorts of dilemmas that we have. Right. So we're going to go into our final section now, and coming back to our patient, she started on abemaciclib, standard dose of 150 BID, but she gets recurrent and persistent diarrhea after her first 2 cycles. She's got some low-grade fatigue. Her absolute neutrophil count is consistently about 1.8. She's had a couple of breaks off drug to manage her symptoms, and it's improved when she's off therapy. But remember, she's a real estate agent. She travels a lot. She's worried about the impact of this on her quality of life and her work. So she's restarted, and she's still getting further symptoms, and the dose is still the same. So this is a nice segue into our final presentation from my colleague, Patrick Nevin, who will look at mitigating adverse events and in maximizing patient adherence to therapy and maneuvers to do that. Patrick.
Thank you, Stephen. So it's my pleasure to run a couple of slides. After that, the patient has known her risk of relapse, and we discuss that adding on an extra treatment might help her, and 6% less chance of developing metastatic disease is a lot. So as you voted on the first question, your main concern is how can we get this patient through this treatment, because there is quite a lot of side effects, and indeed diarrhea is the most reported side effects. And here you can see that apart from diarrhea, there also is neutropenia and there is fatigue as the top 3 most likely side effects of adding abemaciclib for 2 years, as was reported in Monarch E. Another concern is the development of deep venous thrombotic events. like pulmonary embolism. Another rare side effect is interstitial lung disease. So we have quite a bit of concerns that these patients might not be adherent to this adjuvant treatment. And as we have seen from real-world data in Belgium, up to 50% of the patients within 6 months consider a dose reduction to get through this treatment. So it's important how to manage these patients. And here you can see the percentages of the patients at the last analysis who had one or more treatment-related adverse events. Patients with grade 3 or more treatment-related adverse events, and the patients who considered discontinuing the treatment because of this side effect. So consistent with prior analysis, all these patients have these same concerns, and we have to help these patients. So in the adjuvant setting, you can say that patients who are having an older age, they might have more side effects and less compliance with these drugs. And indeed, we see that above age 65, patients have more treatment reductions and more treatment discontinuations, although the side effects were not different. And I do believe that we should see these data for patients above 75 years of age, because also these patients we would like to give adjuvant abemaciclib. So the safety profile of the other compound that is going to be available once it's FDA and EMA approved is ribociclib. There we have different adverse events. There the focus is more on neutropenia. Febrile neutropenia is very rare. There is the cardiac problem with QTc prolongation. There is another point that is the liver toxicity, which is more likely with ribo than with abemaciclib. So there are different concerns, so different compounds and different side effects. Here you can see with abemaciclib, when we focus on the adverse event burden, reported in the histograms in different colors. For the patients who had specific concerns, if you report median levels of quality of life, you will miss quite a lot of patients. And if you ask the patient, how much are you bothered by side effects of adjuvant abemaciclib, then you can see that there is quite a concern of these patients when you express that by a degree of having these bothersome symptoms. If you focus on diarrhea, there is a lot of diarrhea, and you have to tell this patient before you get into the treatment that this is a major concern, and you can see that from the figures in Monarch E, that the patient-reported outcome, the first initial cycle, you can see that up to 50% of the patients see that as an important concern, whether it's quite a bit or very much. So you have to take this absolutely into account. So diarrhea is the most important point when you discuss side effects of these patients. Fatigue, we all know that these patients have had prior treatments, and most of these patients had adjuvant chemotherapy. So an extra drug is giving more fatigue, and if you compare it with the patients who didn't have adjuvant abemaciclib, there is a clear issue about having more tiredness, and a lot of these patients were already, as you can see, tired at baseline. So fatigue is an important issue. Here you can see in the histograms by time since the start of the treatment, expressed in months, the patients who discontinued the treatment because of adverse events, that it's especially in the first cycles that you have to deal with these side effects. And again, diarrhea, fatigue, and neutropenia were the most important concerns. So dose holding and dose reductions are clearly related to the degree of the adverse events. And you can see again that diarrhea was the most frequently reported reason for dose holding and dose reductions. We have to tell the patients that after 6 months of treatment, about half consider stopping the treatment or have had dose reductions. That's what we see in our daily practice, at least in our country. And we should tell the patients that we don't know exactly which drug dose they need. And if the patients are considered a lower dose, then we tell the patient that it's as efficacious as with the standard dose. Doesn't mean that you can start with a lower dose, because these patients were selected for a lower dose based on the side effects. So we cannot permit to start with a lower dose. So that's what we consider if we reduce the dose or if we delay the dose. You can have twice dose reductions. You have to clearly monitor these patients, not only for side effects, but also for hematological problems that the patients don't feel, even if they are not fatigued. So there is a clear standard of care how to see these patients and how frequent. It's important to give these patients feedback if they come back to you. And sometimes you cannot wait 2 weeks because some of these bothersome problems do already appear the first couple of days. So different methods to measure adherence and to educate these patients. It's very important to improve adherence and persistence for patient education. In my institution, we have an onco-coach. It's a nurse who goes through all these potential side effects. We give prescriptions for loperamide. We do advise hydration. We do advise dietitian measures to lower the frequency of diarrhea. So it's important to educate. It's important to give a prescription for loperamide, not to give it as a prevention, but once the patient reports loose stools. There are also a lot of electronic tools, like CADO, that has been tested already, and to give patients more feedback once they need you, also in the weekends. I think it's very important. So the prophylaxis and management of diarrhea is important to consider. Like in this patient, she reported grade 2 diarrhea. It's important to tell these patients, even after a couple of days, really, if it's grade 2 or more, to stop the drug, to go back to grade 1, and to restart, unless there is a persistent diarrhea, which is not disappearing within 24 hours. So you have to talk to these patients. These patients have to be able to give you feedback and to manage the diarrhea, because that's the most important hurdle when you give abemaciclib. So, Stephen?
Thank you very much, Patrick. So the key message, I think, is about the ability to keep patients on therapy, because it's those that stay on therapy that derive the benefit. And those Kaplan-Meier curves that Joyce, you showed at ESMO, I think are very reassuring that even if you had a 1 or dose 2 reduction, your absolute benefit was not diminished. If anything, on those curves, it was slightly above. So there is no loss of efficacy, and you find the dose that's right for the patient. So let's just discuss the case again. And in terms of Joyce, if you were having this patient and you were trying to manage the diarrhea, at what point would you tell her that you need to think about dose reducing? Because we had grade 2, 1 event you can redose, grade 2 persistent. What would your advice be, and who gives that? Is that you or your clinic nurse, and how are you communicating with the patient?
I think I've learned that patient education from the beginning is really critical. Patients need to know what to expect. I find about 5% of patients have grade 3 in the trial, and I tell people very explicitly that if they have a crazy amount of diarrhea, do not take your next pill. I have found that that's necessary, to be very, very explicit about that. That's helped a lot. We see the patients every 2 weeks for the first 2 months, as was done in the study. I think it's super important. I see the patient monthly. My nurse practitioner sees her the other 2. And basically, I try to get the gals to hang in there 6 to 8 weeks, because a lot of times it's very diet dependent, tachyphylaxis, they figure out maybe a little half of an Imodium or something will work. So I try to get them to hang in there 6 to 8 weeks, but you can just tell if they really are having persistent grade 2 all the time, it's really not abating, it's time for dose reduction. The other thing I would say is that women over the age of 75 have considerably more. It was mainly in Monarch E patients over the age of 75 who had really substantial stopping of the abemaciclib. So I am cautious. That's the one group I do start with 100 milligrams.
Yeah, I mean, the recommended indication is to start at the full dose. But I think, there's a lot of times in clinical practice, we get a feel for how our patients are. And yes, the elderly patients do have often more comorbidities, and they're more likely to need dose reductions. But the key message, I think, is early and regular interaction with the patient in the first couple of cycles of treatment. And then, by and large, the vast majority of patients are able to find the dose that's right for them, stay on drug, and continue. And whether that's a nurse-led clinic, a face-to-face, or telephone, I think if the patient knows they've got that interaction with you, that's really important. Patrick, one of the other key, the second or third most common adverse event was fatigue, and 95% of patients have come off the back of chemotherapy. They may have completed some radiation therapy, and we know in clinical practice, fatigue's already there as a baseline, and they go on to endocrine treatment. How do you manage that with this therapy? Because we're not seeing a lot of myelosuppression or neutropenia, and it's often on the back of all of their prior treatment. What are the sort of clues to manage the fatigue? Because it's probably completely not underreported, but it's not as well recognized as something physical like diarrhea or a measured neutropenia.
Well, sometimes there are reasons to be tired, even if 3 out of the 4 patients in Monarch E were already tired before starting on abemaciclib. I think sometimes it might help to look into the blood counts, and some patients are a little bit of anemic. I also think I am a big believer of onco-revalidation, which means that physical activity might help these patients to go over the fatigue. That's independent, of course, of abemaciclib. But first of all, you have to explain these patients that that's one of the side effects, and that the patient, that's not the reason to stop the drug, but 6% less of metastatic events within 4 years is huge.
Yeah, I think motivation in this patient group is driven a lot of the time by their risk of recurrence. And I think now we have very secure data that, without CDK inhibitors, despite everything we can do, 1 in 4 will relapse by 5 years. That's pretty strong motivation and got people into the trial. Whether patients with lower risk of recurrences will have the same level of motivation for CDK inhibitor, is something that will have to evolve. In terms of creatinine, Joyce, I get some letters from general practitioners who may have done a routine blood, and all of a sudden the creatinine is, quite markedly elevated, and they write back and say, I think the patient's got AKI. Can you just mention about creatinine and the management of that?
Yeah, it's simply a observation, sort of a clinical observation of elevated creatinine that's expected because the abemaciclib just competes for excretion with creatinine, but it doesn't. If you actually do a cystatin A evaluation, their renal function is normal, and it goes back to their baseline creatinine. So it's simply a paper toxicity to be aware of, and to just make sure the patient knows it so that her other physicians will not be concerned about it.
Yeah, I think that's right. And you mentioned, Patrick, venous thrombotic events. Is that relevant to choice of endocrine partner with abemaciclib?
Well, it was seen that it's more likely in patients who were on tamoxifen. That's what we all know. But even if patients were on an AI, it's still possible. So I think we have to not ignore it. And it's rare, but it does happen, yes. But tamoxifen related, yes.
And tamoxifen is an initial therapy. This was a global study in 600 hospitals in 40 countries around the world. So we didn't mandate ovarian suppression as in the NATALY trial. Tamoxifen was an initial treatment in many patients, but remember, chemotherapy, which all of these had, would often induce menopause, and these patients then transition onto aromatase inhibitors as we would do in standard practice. So although the drug can be combined with tamoxifen, I think in this patient population, the vast majority of premenopausal are transitioning into ovarian suppression or should have it anyway, as the SOFT and TEX trial data. And certainly the FDA and EMA recommendations are that if premenopausal therapy, OFS, should be used. So there are a couple of microphones if you've got a burning question and don't feel tech friendly enough to QR code a question. While any of you are thinking about that, and I've got literally about a few more minutes left, some of you had sent some questions in on the iPad here, so I'll come up with those and ask, is CDK inhibitor therapy in the adjuvant setting and a patient subsequently relapses in the metastatic setting? Does that mean we can't use CDK inhibitors in metastatic setting, or what are our sort of current guidelines? So Europe and US, Patrick, what do we do if we've had adjuvant CDK inhibitor and sadly the patient 2-3 years later then relapses? Have we kind of messed things up for metastatic treatment?
We would discuss this case, of course, and I think we would come with an answer. It depends on whether she relapses during this CDK4/6 inhibitor or whether there is a long time lapse between the last intake and the relapse. So I think she definitely can get, again, a CDK4/6 inhibitor if there is a long time between the last drug and the relapse, yes. There are, of course, clinical studies ongoing.
There are, yeah. And a year is often a sort of pragmatic cut-off point, like platinum re-challenge in ovarian cancer. So, but again, not based on a lot of evidence, but based on likelihood of it still being endocrine sensitive versus endocrine resistant.
Of course, we would do an NGS screening of course, if to see any targets. Or
Joyce, if the recurrence is like about 3 months after they finish their adjuvant therapy, where do you think that leaves us in choice for, and it's nodal and bone disease, for example, rather than liver, lung, symptomatic, so on. Where does our thinking in metastatic therapy go then?
3 months after finishing abemaciclib?
Yeah, and on adjuvant AI.
That's pretty concerning that she didn't really get a robust improvement in her outcome with abemaciclib. I would not be inclined to go to another CDK4/6 inhibitor. There was intriguing when Nick Turner showed some of the molecular analyses. There was this intriguing finding that c-MYC amplification predicted for no benefit. That was just a hypothesis generating, but if that was a subset, of the patients, so with larger analysis of Monarch E, that would be interesting to know. Like phospho-RB, loss of phospho-RB, I don't think it's validated enough now, to say that that is a definite resistance to CDK4/6. But hopefully we're going to get smarter about these things.
Christine Desmet presented some data in this room this morning, actually, with baseline genomic changes, and showed that the RB loss was a predictor of relative resistance, but other germline mutations weren't necessarily. Question in microphone 1 or whatever there. Hi.
Hi, Shane White, Australia. So if you adopt the poetic approach and you don't get a Chi-67 fall, I'm guessing there's some implication there about primary endocrine resistance. So then is abema going to overcome that resistance mechanism? Are we hoping that? Or, we do know there's some data of abema as a single agent. What are we kind of hoping and expecting for in that circumstance?
Yeah, well, that's a very nice lead-in question to a current trial that we're doing in the UK, which is a follow-on from Poetic, called Poetic A. We're acting exactly that question. So anything between, a few weeks and a few months of AI therapy, and if the Ki-67 isn't suppressed, we know from the Poetic trial they have a 20% risk of recurrence at 5 years. Very different, very similar to the high-risk node positive. And then we are randomizing those patients to abema or not, regardless of whether because they may be node negative and not fit the standard abema criteria. So we're currently recruiting a trial to address exactly that issue, because we know in metastatic disease that endocrine resistance is very effectively treated by abema with fulvestrant in the data from the Monarch 3 trial. But no, that's a good question. Okay, coming back to another question that we've had here. Patrick, if a patient's going to have some prolonged surgery, say breast reconstruction, what's the advice? And they're on adjuvant abemaciclib. What's the advice there? Do we?
Actually, we have a current advice because we have these patients, and we stop abemaciclib a week before surgery, and we restart once the patient is walking around and fit enough, yes. So we interrupt abemaciclib. There is no hard evidence, but we do.
Yeah, we do exactly the same. And it's basically because you've got a little bit of neutropenia, you want to not have that, and you don't want to have any impact on sort of wound healing and outcomes from surgery. And in terms of, we talked about the recurrence score, does it have any influence? And I think the data is now quite clear that you don't have to use that as a deciding factor for adjuvant CDK inhibitors. And Joyce, do you think the choice of endocrine therapy matters here? We touched a little bit about tamoxifen transitioning over. What's your sort of go-to therapy in a high-risk premenopausal patient, by and large?
LHRH agonist plus AI in the high-risk patients. There's an online algorithm from the Dana-Farber. You can just Google up you can see exactly what your patient's risk is and what exact degree of benefit they get from the LHRH agonist AI versus tamoxifen alone, et cetera. So, but I really think that for these high-risk patients, we want to use AI plus a LHRH agonist. But the Monarch E did show, as you said, some patients transition initially to tamoxifen because you're not exactly sure what their menopausal status is, and then we switch them over once we're more certain. Yep. But regardless of which endocrine agent they had in Monarch E, there was benefit.
Good. Okay. All right. We're just a few minutes past our allotted hour, so I'd like to thank my colleagues, Patrick, Joyce. I'd like to thank PeerView, and thank you, all of you, for giving up your lunch in the sunny weather outside to attend, and hope you found that instructive and beneficial, and see you all again soon. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/WUM860. This activity is supported by an educational grant from Lilly.